Next, we will have Professor Francisca Oladipo and Professor Dr. Mirjam van Reisen. So Professor Francisca Oladipo is the Executive Coordinator of the Africa and Asia Implementation Networks of the Virus Outbreak Data Network Africa, VODAN. She is a professor of computer science from Nigeria, and she was the first woman to serve as a member of the governing council of her university and the first female head of the Department of Computer Science. Welcome on stage. We have Professor Dr. Mirjam van Reisen. She lives in Brussels and travels from there to Tilburg and Leiden weekly, as she is the professor in Tilburg University in International Relations and also holds a chair at the LUMC in Fair Data Science. She's the coordinator of the VODAN African Implementation Network, and with a long and impressive track record on the African continent, we're happy to have her here. Welcome on stage.
Thank you very much. We're both honored to be here today to speak on the VODAN Africa initiative. So I'm going to start to talk about what VODAN Africa is, what actually inspired us, why did we decide to do it? And then I'll hand over to Professor Mirjam to speak on the methodology. Earlier today, we heard about getting things done better when you co-create. VODAN Africa is one of such co-creation, and I'm going to excite you to see how we moved from ground zero actually, to the point where we are today. What exactly was the problem? I mean, why did this group of people? I am from Nigeria. I've never been to the Netherlands other than Amsterdam. And then I had to work with Professor Mirjam and a number of other people here to achieve this initiative. In Africa, there has been that problem of missing health data, digital health data. We had the Ebola virus, and after the whole outcry, and then there was the treatment and everything, and the whole thing died down, the data was nowhere to be found in Africa. So situations happen that whenever there is any health crisis, data is collected from countries, then the data will be exported elsewhere, outside of the jurisdiction of the country where the data is collected. So when there is any other outbreak, there is nothing for our healthcare workers in Africa to work with, to learn from experiences of previous pandemic or epidemics. Then at the health facilities level, in few cases where we have the HMIS, the data is unavailable at that level for them to do analytics. And so in 2020, when the COVID pandemic came, we talked about it. What can we do to help the healthcare workers in Africa? I mean, we're Africa, we don't manufacture vaccines yet, but there should be a kind of science that we can do. If we do communications, who is really going to believe anything much? Is going to give so much credence to, communications from Africa trying to help people through the virus. But if we can help our healthcare workers by ensuring that they have access to data that they need at the point of care, and then also ensure that for Africa, the data is no longer removed, but stored in Africa under the authorities of the governments of the countries in Africa where they're collected, then our scientists and researchers will have access to data that has provenance, because now it's not like somebody sneaking in to get data for you from a health facility, but you formally have access to this data, and that was the problem we're trying to solve. And so we moved, supposed to move this way, right? And so we had to come together. There was lockdown everywhere, but we had to find ourselves. And so universities in these countries from Uganda, Ethiopia, Somalia, Zimbabwe, Liberia, Nigeria, and Tunisia, and of course Tunisia and Tanzania, we came together to form a network with hospitals at different levels, primary, secondary, and tertiary healthcare, with university hospitals and then ministries of health in these countries, we came together to form the network of partnership of VODAN Africa. I'm going to speak about Philips Foundation, GoFair, and how they came in the next slide. Can you help me advance the slide? Sorry, I don't know why it's not. Yes, thank you. And so I'm going to speak on co-creation. We have these countries in Africa, but we cannot do it alone. We needed to co-create. And so up in Europe, we have the Leiden University Medical Center. We had the Leiden University working with graduate students and professors from these institutions, Tilburg University. We were able to form part of that technical partnership. And then, of course, Kazakhstan, China, and Indonesia. We work with researchers from these three countries, and then China especially, even in the context of COVID-19, they gave us a platform to actually publish the result of our work. And then coming to North America, we have Stanford University. They already have the CIDR metadata. Africa now had to retool and re-engineer the CIDR metadata to suit our purpose to build the fair data points for the purpose of Africa. And of course, the San Diego Supercomputer Center in North America still gave us a platform. Europe was very, very critical in the success of our projects. So we had the technical support of the GoFair Foundation that gave us actually the platform to build data, healthcare data that are findable, accessible, interoperable, and reusable in 88 health facilities in Africa. And of course, we have the Invest International, we have the Philips Foundation that provided the funding for us. And we had Cordate also here in Netherlands that provided some administration. So you see the way we moved across Africa, Europe, North America, and then Asia to build the network of this solution. It really wasn't easy because we had, I'm so sorry about this, I'm trying to advance my slide. It's going, it's supposed to move forward. Right. We had to work under very difficult conditions. There was the war in Ethiopia, for example, and then there was a kind of two sides, the Tigray and then the other part of the country. But despite this divide, at the level of VODAN Africa, the two teams were able to work together. And then we had health facilities from those two parts of the country, and were able to deploy successfully there. In Nigeria, we have the bandits in northern Nigeria, and where we have the largest number of health facilities in Nigeria today is from northern Nigeria. So despite the security situation in Nigeria, the war in Tigray, lack of internet and all that, we were still able to come together as a team to deploy in these 88 health facilities. And we successfully did the deployment. You're going to be seeing that later today. So Professor Mirjam, I am going to hand over to you to speak on the methodology and how we're able to achieve this technically. See how you can advance this slide.
Is this? Oh, this one. Ah, yeah. Do you want to introduce?
Okay, yes, that's fine. So, in addition to the team of the data stewards now in the 9 countries, we also have a leadership team across Africa and Asia, and I'm not going to go through all of them, but we've been able to, through this team, also build capacities. So in order not to keep this knowledge to ourselves, we've been able to develop curriculum with the sponsorship of NewFig. We've been able to build curriculum, and we've been able to also train people in different expertise, data stewardship, data access permission, data quality monitoring, somebody in charge of visualization. These originally were not even data scientists. We have medical persons among us. We had people who read fine and applied arts. We had people who were in statistics. We had people who were like clerical officers in hospitals. But we've been able to develop different competencies and then different leadership within the team of VODAN Africa.
All right. So here you see the actual realization of VODAN across these continents, as Professor Francisca has already explained. And so the essence of this is that we are working with something that Leiden University is very, very proud of. And that is how to make sense of the exponentially growing data as findable, accessible, under well-defined and clear conditions, interoperable and reusable. And this FAIR is the principle that we have applied here to the health data, the medical patient data that are produced in these 88 health facilities. And for this, we re-engineered the software that was produced as cloud software in Stanford in Cedar to a software that was deployable at in each of those health facilities, including very remote facilities. So here, yes, this is just a short video. I think after in the workshops, we can go a little bit more in detail in some of the technicalities of this. But what is really, I think, the essence to say and what we were trying to resolve at once is, first of all, the meaning of this data that is produced at point of care. As Francisca was saying, it was really shocking for us to find at the moment when we were exploring this issue of lack of data from the African continent. We came in one of the health facilities where data was being put in by a data clerk sitting behind the computer. And when we asked the question, what are you doing with this data? The answer was, well, we don't know, because we don't know where the data goes to. And so then we were asking, but why are you putting in this data? Where is this data going? And he was saying, well, it goes to the ministry and then it goes to Norway. So the issue of using the data at point of care was something that we realized wasn't naturally happening when data was being taken from health facilities for analytics elsewhere. So we thought then also starting this initiative at the start of the COVID crisis, where there was a really serious underrepresentation of data from Africa, we thought we should be able to combine these different use cases. And so that is really the essence of what we have been trying to do. That is, if you look there in the left-hand corner, you see the hourglass model. And so what we do is we create the data as machine actionable, highly semantically described data, which allows them to become visitable and interoperable and reusable. And that provides us then with the possibility of creating a very high quality, fair and ethical data pipeline for the algorithmic revisiting of this data for different use cases. And so here you see the pipeline of accessibility depending on the granularity of the data and the sensitivity of this data at the different levels of their processing. And so that allows us to really create an interoperable network around these health facilities in which the problem of vertical, different unconnected data pipelines is now retransformed into a connected, interlinked modeling. And the core of that work is to create the data as machine actionable, and which then allows us complete and 100% data ownership, that this data never leaves the place where it is produced. And so the value for the data analytics is then organized through the data visiting by the algorithmic process. And this is also why it enabled us to do the analytics across different jurisdictions, because in fact, within different jurisdictions, we are able to visit this data as long as we have sufficiently well arranged the process of the data access. And so this is the schema. I won't go into it in detail, but you see here, in fact, the 88 health facilities that we have. The data is entered once, only once. It's reposited within the health facility. And then here we have at this point 4 different use cases. The automatic entry into the HMIS system, often the HIS2, the local facility data dashboard for local health facility analytics, the data analytics across all of the 88 health facilities, and then the blue one up there, which is now allowing dynamic data querying, and that is really where we are going to see the big advance for future innovation. We believe. So we're very proud of the fact that we were able to, in this short time, to include 88 health facilities in 8 countries. And what that showed to us is that there really is a very high potential and high willingness. And the key to that, as was the opening of Francisca, is the data ownership. That is what is going to be driving this innovation. Thank you very much.
I'm very happy that we're going to see you in one of the breakout sessions. So I would like to ask the audience to keep their questions for the breakout sessions, because we're running a little out of time. Thank you very much for a beautiful presentation.